Hi everybody, I'm RAÚL CHÁVEZ and I'm going to present our poster named Invasive Pulmonary Filamentous Fungal Infection in an Immunocompromised Patient, Mulch Pneumonitis. Here we present a case report of a man of 39-year-old who had the history of chronic granulomatous disease, primary antiphospholipid syndrome, protein C, and antithrombin 3 deficiency. He was admitted to our hospital. He used to live in a rural community and work with sheep. On August 16, he had leptotalgia, so he went to our hospital where he was diagnosed with acute otitis media and received outpatient treatment with amoxicillin clavulanate treatment. 1 week later, he came back with fever, headache, and cough. The examination was completely normal. The labs reported neutrophilia and C-reactive protein elevated in 23. The thorax CT scan showed bilateral diffuse pneumonia. Because of patient's immunodeficiency, we start treatment with meropenem, vancomycin, trimethoprim, sulfamethoxazole, voriconazole, and clarithromycin. He continued with fever and respiratory distress, perhaps our treatment, so he went to another thorax CT scan which showed progression of the pneumonia. The blood culture and serum galactomannan were negative. The infectious disease expert suggests antibiotic change with imipenem to cover nocardia, linezolid, doxycycline, clarithromycin, trimethoprim, voriconazole, and amphotericin B. He had refractory hypoxemia, so he was referred to ICU for invasive mechanical ventilation. The pulmonary and critical care team performed a bronchoscopy that showed purulent secretions in low pulmonary airway. While he was intubated, the interstitial lung expert suggested the diagnosis of hypersensitivity pneumonitis, so the patient received methylprednisolone 60 milligrams every 24 hours. He was successfully extubated after 5 days of treatment. We decided to repeat the thorax CT scan, which showed an impressive improvement. Finally, the bronchoalveolar lavage reported as per Hilus-Niger rhizopus, concluding Mulch pneumonitis. So he continued treatment with amphotericin B first and posaconazole later. A PET-CT ruled out incubation of rhizopus. The patient received antifungal steroid therapy for 4 weeks. Then he left the hospital without any complications and with full recovery. In conclusion, our patients with chronic granulomatous disease have the risk of unusual infections. The invasive pulmonary filamentous fungal infection is an important diagnosis to consider, and the correct and prompt therapy gives a better prognosis to these patients, as in this case. Thank you.